Schuhmann is one of our chief residents. She's a fourth-year resident here. She did her undergrad at U of L as well as medical school and decided to hang around. Unfortunately, it's a poorly kept secret. We'd like to keep her around even longer, but she may have other plans, including telepsychiatry, which is not too disappointing. She's going to talk to us today about dialectical behavioral therapy. She's won most of the major awards in our department in her course as a resident. She won the inpatient award as a second year. She split the outpatient award as a third year. She's been a chief resident for the last 2 years. It's really a pleasure to hear what Dr. Schumann has to say today.
Thank you. All right, today I'm going to be talking on dialectical behavioral therapy. I chose this topic because as we were seeing applicants come through for residency, they kept asking, what is something that you don't feel like you're taught well, or what is something you feel like your program's missing? And I feel like we're taught everything really well. Other than maybe DBT, we hear about it, but beyond that, we haven't traditionally been taught very much about it. Now Dr. O'Connor is here, and I think he's picking some of that up. So some of the third years will get an hour of this at the end of this semester, but beyond that, I know the fourth years at least didn't really have exposure to it. So the objectives today, we're going to discuss the origins of DBT, review the targeted patient populations for DBT, the biosocial theory of borderline personality disorder. We're going to learn the basic functions, the components, and the stages of DBT, talk about some of the DBT intervention techniques, and then we'll review some of the research and basic study outcomes as related to DBT. So dialectical behavioral therapy, or DBT, was created by Marcia M. Linehan in the 1970s. So she was born in Oklahoma, and she was actually admitted to a psychiatric hospital around the age 17 or 18 and diagnosed with schizophrenia. She felt she more likely had borderline personality disorder. While she was at the hospital, she was frequently in seclusion and restraints, received ECT, was treated with Thorazine and Librium. She had a lot of self-harm behaviors. Anything she could get a hold of, she would try to cut herself, stab herself. When they took those away, she would bang her head on the floor, on the walls. They think that likely she didn't continue any sort of medications when she was discharged from the hospital, but she did receive some in the hospital. She eventually went on to get her PhD in social and experimental personality psychology from Loyola, became a professor, adjunct professor, and she is the director of behavioral research and therapy clinics. And this is one of her quotes, is, "You can feel like a mental patient, but that doesn't mean you have to act like one." So DBT was originally geared toward chronically suicidal patients, like Marcia Linehan herself was suicidal, after she noticed that they were failing traditional CBT techniques. Three main observations came into play when she was developing DBT. So one, people, especially people with borderline personality disorder, often felt criticized when the focus of therapy was on change, and so they would either quit therapy or start attacking the therapist. During individual therapy, it was very difficult to during a 1-hour session or 30-minute session, it was difficult to manage people who had acutely suicidal behavior, as well as trying to teach them new skills to manage their behaviors and motivations to die. So patients with borderline personality disorder, also during traditional therapy, they would reinforce therapist iatrogenic therapy, meaning that if the therapist was talking about something neutral or pleasant, they would let the therapist continue with that stream of thought. But as soon as the therapist started addressing change or something unpleasant to the patient, that's when they would find some way to punish the therapist, either by lashing out or leaving or starting to show up late. Eventually, the treatment evolved specifically for borderline personality disorder, but then as time went on, it was found to be effective for other disorders that are more difficult to manage and involve emotion dysregulation, including substance abuse, binge eating, suicidal adolescents, depressed elderly, some post-traumatic stress disorder. So just a review of borderline personality disorder, because a lot of what we're talking about today deals with borderline personality disorder. So this is from the DSM. Borderline personality disorder is a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. And you all can read through those, but the bolded ones are the key things. So they have sense of abandonment, whether real or not, unstable and intense interpersonal relationships, identity disturbances, impulsivity in at least 2 areas, recurrent suicidal gestures, thoughts, behaviors, self-harm behaviors. And of note, 3 to 10% of borderline personality disorder patients commit suicide, and 75% have some sort of self-harm behaviors. Affective instability, chronic sense of emptiness, and inappropriate, intense anger or difficulty controlling anger. So this slide talks about the combined capability, deficit, and motivational model for borderline personality disorder, which states that borderline personality disorder patients lack important interpersonal self-regulation and distress tolerance skills. So when we talk about DBT, those are the things that DBT is targeting. There are also personal and environmental factors that often inhibit the use of the skills that they do have, and they reinforce the negative dysfunctional behaviors. The biosocial theory of borderline personality disorder states that there's a biological predisposition toward emotional vulnerability and also an invalidating rearing environment that produces emotional dysregulation. So you have people who are predisposed to having quick, strong emotional reactions and with a slower return to their baseline emotion. This could be due to what's been found to be a hyperactive amygdala or a decreased, an underactive prefrontal cortex. The invalidating rearing environment refers to any sort of environment that punishes, ignores, invalidates, or trivializes the patient's emotions, so especially while they're growing up. So for example, if you have an abusive environment, that would be considered the invalidating rearing environment, where kids don't learn to accurately label their emotions, they don't learn to trust their emotions, they also don't learn to appropriately validate or evaluate their behaviors. So in borderline personality disorder patients, they have intense emotions, which then triggers their caregivers to invalidate these emotions, which then causes more intense emotions, and it's just a cycle that they both play off of each other. Borderline personality disorder patients have difficulty regulating psychosocial arousal as well as turning away from emotional stimuli. They have maladaptive methods of altering emotional experiences, and essentially there's a breakdown between cognitive, behavioral, and emotional response systems when any intense emotion is present. So what does the term dialectical mean? Because like I said before, I knew that DBT stood for dialectical behavioral therapy, but what does that mean? I had absolutely no clue. So dialect is the process by which a phenomenon, behavior, or argument is transformed. So there's an initial statement about an issue, and that's known as the thesis. Then there's an opposing position about that statement, or the antithesis. And the synthesis is the combination between the two that embodies the valuable features of both. So it's kind of like the middle ground between the thesis and antithesis. Dialectical philosophy, there's a reality that's composed of interrelated parts that can't be defined without referencing the whole. Likewise, a system is made up of a lot of individual parts that are changing and influencing each other. So the parts influence the whole influences the parts, and you can't really address either one without addressing the other. So that's what DBT focuses on, addressing the whole patient and not just one part of their personality disorder. Borderline personality disorder patients, they oscillate between extremes of refusing to collaborate, attacking the therapist, emotional escalation, or being completely pleasant and cooperating, collaborating fully. So the therapist really has to work to balance change and acceptance with each interaction they have with the patient. Dialectical also refers to the multiple tensions in therapy with with borderline personality disorder or suicidal patients, and enhancing dialectical thinking patterns to replace rigid dichotomous thinking. So some dialectical challenges in DBT. This is one of the things you'll see come up several times throughout the presentation, is the balancing of accepting and change. So you try to help the patient engage in functional, life-enhancing behavior even when they're having intense emotion. So in some way you're accepting emotion, but you're trying to change the behavior or how they respond to that emotion. Appearing accepting and non-judgmental at each moment, while at the same time keeping in mind the ultimate treatment goal. So Marshall Linehan said to move the client from a life of hell to a life worth living as quickly and efficiently as possible. So you want to accept the patient for who they are, where they are, but at the same time you don't want to become stagnant and stay in that one spot. You have to make little steps to progress forward. Balancing centeredness with compassionate flexibility, so believing in yourself, the client, the treatment, but also being able to modify the treatment when new things come up. So when you receive new information, you have to be able to modify what you're doing. Or when things happen and you feel like you have to repair the relationship between the therapist and the patient, because these are difficult patients to manage and things are going to come up where you feel like you've made a mistake, and you have to be willing to step back and say that you still believe in what you're doing, but you may have made a mistake. And finally, balancing a nurturing style with a demanding approach. So you want to teach, coach, assist the patient, but you don't want to let them just stay in the same place. You have to, at times, drag out and almost force new behaviors and to help them recognize capabilities and capacity to change, to help the client do for themselves. So you don't want to be doing everything for the client. You want to help them do it for themselves. Some basic propositions of DBT, and these are from Dr. Tasman's book. You assume that the patients are doing the best they can and that they actually want to improve, that they need to do better, try harder, and be more motivated to change, that the patients might not have caused all of their problems that they have, but they still have to be the ones to be willing to solve them and work for them. Suicidal borderline individuals' lives are unbearable as they currently are, and therefore they have to learn new behaviors. Patients cannot fail in therapy, and therapists treating borderline personality disorders need support. So the 5 functions of DBT: to enhance behavioral capabilities, improve motivation to change by modifying inhibitions and reinforcement contingencies, assure that new capabilities generalize to the natural environment so they're able to apply these to their life rather than just in the therapy session, structure the treatment environment to support the patient and therapist capabilities, and enhance the therapist capabilities and motivation to treat patients effectively. So we accomplish these 5 functions by the DBT components. So each week, patients participate in 4 different weekly components, well, rather 3. The individual psychotherapy, where you address motivation and skills strengthening as related to the patient's specific life. So it's more individualized and geared toward just the patient. You have group skills training sessions. They meet once a week for 2 to 2.5 hours with a group. There's a leader who teaches new skills, then they're assigned homework to go and work on. There are 4 modules that are taught: mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance. And these are taught over a 24-week period, and then the course is repeated. So essentially you get the same thing twice, and it's a year-long skills training group. There is phone consultation with a therapist to address application of coping skills. So you give the patient permission to call you as needed when they're in crisis to talk about how they're going to manage it. And it's more in-the-moment coaching. So if they have these skills, can they actually apply them when the time comes? And then finally, the therapist consultation team. So this is more geared towards the therapist rather than the patient. They meet with a team to provide support and ensure that there's still effective treatment going on. Otherwise, these patients are very difficult to manage on your own, and some people tend to get burnt out. And we'll review all of those components in a little bit more detail. So there are 4 stages of DBT. Stage 1 is to just stabilize the patient and achieve behavioral control. So there's a hierarchy of how the behaviors are addressed. First, you want to decrease the high-risk suicidal behaviors and thoughts before anything else. You want to make sure the patient is safe. Once that's under control, then you move on to decreasing therapy interfering behaviors. So these would be things like showing up late, skipping appointments, calling at unreasonable times, not returning phone calls. Once that's under control, you move on to the quality of life interfering behaviors. So addressing things in the patient's life like depression, substance use, chronic unemployment, homelessness, things that interfere with their life. And lastly, you increase behavioral skills such as the emotion regulation, interpersonal effectiveness, distress tolerance, mindfulness, and self-management. So those 4 modules that are addressed in the skills groups. Stage 2 is to replace the quiet desperation with non-traumatic emotional reasoning. The goal is to move into full emotional experiencing. So the behavior is now under control, but the patient is still suffering, and this may be because of past invalidation or trauma, and so you want to move them beyond that point. Stage 3 is the goal is to achieve an ordinary happiness and unhappiness. So you're not saying they're never going to be unhappy, but you want it to be an ordinary unhappiness and decrease ongoing disorders and problems in living. So you define life goals, you work on their self-esteem, their self-respect. Stage 4, not everyone complete stage 4, but essentially you're trying to resolve a sense of incompleteness and achieve joy and possibly transcendence. So there's more of a spiritual element to stage 4 where they're trying to find a deeper meaning in their life. It's no longer just having normal happiness and unhappiness. They're actually trying to have joy and transcendence. So this is a list of some of the basic DBT strategies. We've talked about some of them, like balancing acceptance and change strategies, nurturing and demand, capabilities with limitations. Some of the other ones include moving with speed and keeping the patient slightly off balance, and we'll talk about that in a later slide about what all that means. Taking wholehearted positions, looking for what the patients don't include in their point of view, so you don't just accept what they say for what it is, you actually question stuff. But you advocate for a middle ground. And this is, again, balancing the acceptance and the change strategies. You can use metaphors, stories, parables. You can play devil's advocate to help encourage the patient to think outside the box. And you extend the seriousness or implications of the patient's statements. So again, you don't just let them say that they're going to kill themselves and not question it. You have to help them understand why that's so serious to say, what it means, what the consequences of saying something like that are. This is another just table with several of the DBT interventions. The top part right here are common interventions to other behavioral therapies, and the bottom part includes some of the more unique dialectical behavior therapies, and we're going to talk about some of the ones on the bottom. So distress tolerance means helping the patient tolerate pain in difficult situations and not necessarily trying to change the situation or necessarily changing the pain. Being able to recognize situations and impact without being overwhelmed by them so that they can be in that situation and address the issues but not feel like they can't handle it. Some skills taught during distress tolerance include being able to temporarily distract themselves from unpleasant emotions, whether this is going and listening to music or watching a television show before coming back and addressing the issue. Self-soothing, using imagery, finding meaning in the feeling, so knowing that you're not just experiencing this for no reason. Praying, encouraging yourself to continue on. And distress tolerance is more acceptance-oriented. Interpersonal effectiveness, on the other hand, is more change-oriented, so you're teaching how to ask for what you want or say no while maintaining self-respect in relationships. So some skills taught during interpersonal effectiveness training include asking clearly for what you want, appearing confident, explaining positive consequences if you obtain what you're asking for, being able to negotiate with people, use appropriate language, maintaining attention to another, being able to provide validation to another person, being truthful and sticking to your values. So this is all how you relate to other people and how you relate to other people to obtain what's best for you as well. Mindfulness has a very Zen influence. It essentially means being fully aware and present in the moment, being present in the current experience, the here and now. So you let go of attachments, become one with current reality without judgment, or effort to change what is, and to really participate in the experience now. This is another acceptance-oriented technique. So practicing mindfulness includes 3 major components: observing, meaning non-judgmentally watching the environment. You're not thinking of anything as good or bad, you're just watching what is. Describing the environment, and then finally participating in the actions and experiences in a non-judgmental, one mindful way. And one mindful way just means that you focus on one thing at a time. That way you don't get overwhelmed with the whole, but you still accomplish something. So radically accepting a current situation, thought, emotion, or experience, and having the willingness to enter into a life with awaken and effectiveness. Mindfulness goals would be to increase the conscious control over attentional processes, using wise integration of emotional and rational thinking, and that's finding that middle ground between your emotional reasoning and your rational reasoning. There shouldn't be just one or the other. There's some common middle ground. Having a sense of unity or oneness with self, others, and the universe. And some examples used in mindfulness to obtain this change are behavioral exposure, emotion regulation, attentional control, and reducing literal beliefs and rules. And we'll go through each of those 4 components because mindfulness is such a big part of DBT. So behavioral exposure means reduce the attempt to control private experiences. So you observe a thought as a thought or an emotion as an emotion without attempting to change them. You don't try to fix, avoid, or change experiences, but rather just accept them for what they are. There's non-judgmental awareness of distressing thoughts or emotions without having dire consequences. Serves as a non-reinforced exposure. So you have a distressing thought, you have the thought, but then nothing bad ultimately comes of it. It serves as a non-reinforcer that maybe the thought wasn't so bad to begin with. For extinction training, one needs active learning of alternative responses to stimuli that elicit unwanted internal experiences. Emotion regulation, the goal is to reverse emotion-linked response tendencies and associated cognitive appraisals that lead to additional suffering. The goal is not necessarily to eliminate the intensity of the emotion, but rather the emotion of the primary emotional response. But to learn new associations with that stimuli that elicit the intense emotion. So you observe, describe, and again participate in the emotional experience without acting on them, and you allow yourself to automatically change the meaning of the event. So it's no longer viewed as good or bad, it just is. So when we talked about not necessarily eliminating the primary emotional response, this is what we're referring to. So there can be aversive or pleasant arousal, and those are going to be there no matter what you do. They just are. So a response tendency to an aversive arousal would be to avoid whatever it is, and to appraise that situation as being bad. In mindfulness, you still have the aversive arousal, but instead of avoiding it, you just observe it. You watch, you look, you're non-judgmental, and rather than appraising it as a bad situation, it just is. The same can be done with pleasant arousals. Instead of approaching it, you observe it. Instead of labeling it as good, you label it just is. Attentional control is a focus on non-emotional contextual details of an emotional memory to decrease the intensity. You learn to interrupt streams of thought that are unrelated to the current moment and turn attention from what you don't want to focus on to what you do want to focus on, and you let go of everything else. So if your mind starts wandering, you learn how to stop it there and just focus on what's going on currently in the here and now. You, again, observe, describe, and participate and decrease attachment to emotional stimuli. Reducing the literal belief in rules. So borderline personality disorder patients often act according to their own verbal rules. That is a relationship between a behavior and a consequence, whether it's real or not. For example, if they speak in public, they may think that people will laugh. Therefore, because of this verbal rule they have within themselves, they avoid speaking, and then they're never able to actually realize the actual contingencies in the environment. So they don't experience what actually happens when you public speak because they don't do it. They avoid it. They label thoughts and feelings as bad. So mindfulness teaches, again, that thoughts are thoughts and they're not necessarily true. And this obviously goes into CBT as well as DBT, that not all thoughts are true, and so mindfulness helps teach that. It doesn't reduce the frequency of the thoughts, but rather decreases the view of the world as good or bad, and allows them to be more open to seeing the actual contingencies. So to trying new things and seeing what happens, rather than relying on this system of beliefs that they have. Validation is a huge part of DBT, and there are 6 levels: active listening and interest, accurate reflecting of behaviors, feelings, and thoughts, articulating non-verbalized feelings and thoughts, expressing that the patient's dysfunctional behavior is actually logical given the biological factors and past learning. So you look at their past and you help them to understand maybe why they feel the way they do or why they react the way they do, rather than trying to make it as a bad thing that they need to correct right now. Expressing that behavior is normal and expected given the current context, and acting genuine. Validation helps develop a coherent sense of the self, which we know borderline personality disorder patients often lack. It helps develop and organize experiences, predict future events, and engage in social interactions more appropriately. It reduces emotional arousal and enhances learning. It increases the motivation to stay in therapy since the environment is more compatible with self-conception. So it's found that if you are with a therapist who believes some of the same things as you believe, as opposed to being with a therapist who doesn't believe what you believe, you're more likely to stick around in therapy with the one who believes some of the same as you. So that's part of why it's important to validate what the patient is saying and telling you they feel. It can be used to influence contingencies within the therapy session. So for example, if the patient's engaged in some sort of skillful behavior that you've been working on, you can validate them more than you normally do. Whereas if they do something that would be against what you've been talking about, it's a dysfunctional behavior, they self-harm, you can withhold some of the validation so that they're more likely to engage in the skillful behavior than the dysfunctional behavior. And finally, it provides a modeling behavior so the patient learns a way to validate themselves and their behaviors and emotions, as well as helping them to learn how to validate other people to further work on their interpersonal skills. Behavioral targeting and chain analysis. Behavioral targets are organized into life-threatening, therapy interfering, and quality of life interfering behaviors, as we talked about before. The patient can self-monitor their behaviors, their interfering behaviors on a diary card, and I'll show you an example of one of those in a minute. The therapist targets the highest priority behaviors first that they've had since the last session. So if the patient comes in and they've had some self-harm behavior, you're not just going to keep on working on their life-interfering behaviors the whole session. You're going to go back to that life-threatening behavior. Chain analysis, it determines a very detailed events that increase the chance that the behavior would occur, the stimuli and the consequences. So you're not just asking the patient to broadly tell you why they got upset. You pick it apart and look at every little minute detail, how they got to that point, why they felt that way, rather than just blatantly accepting that they felt bad so they cut themselves. You want to know exactly what led up to that point. Aversive contingencies. So this refers to the idea that if you have a lengthy discussion about something the patient doesn't necessarily want to talk about, they're going to be less likely to engage in that behavior again. So if they've cut and you've made them sit there and tell you exactly why they cut and what was going on, next time they go to cut, they're going to think a little bit more about it because they're going to realize that you're going to ask them and make them relive it. And there's some sense of shame associated with talking about these dysfunctional behaviors that they've engaged in. Discussing emotional responses and stimuli provokes non-reinforced exposure to emotions. So again, you can talk about things that made you feel bad, and by talking about it, you realize that nothing bad actually happened other than the feeling. It helps the patient recognize patterns so that he or she can see warning signs. So next time they start feeling this way again, they can think back and act differently. The therapist is able to weave assessment and treatment throughout this chain analysis. So this is an example of a diary card. So essentially you have all of the skills over here that you could work on, and the patient just goes through and each day they circle the ones that they've worked on. And it's just a way to monitor whether or not their behaviors are changing or they're working on them at all. Opposite action is an emotion regulation skill. There are 4 parts. Determine that an emotion is unwarranted or interferes with effective behavior. Exposure to the emotionally evocative stimuli. Block the behavior prompted by the emotion's action urge, and substitute a behavior inconsistent with action tendency compelled by the emotion. So this is linked to the exposure-based therapies that you've seen before. So if you act in a way that's consistent with an action compelled by the emotion, it increases the chance that that emotion will recur in a similar situation. So if you let yourself avoid the situation when you start fearing it, the next time you're in a similar situation, you're going to avoid it again because that's what you become used to. Repeatedly approaching the feared situation without a fearful event and blocking the action urge weakens this link between the stimuli and the emotion. For example, like we talked about with public speaking, if you prevent escaping or avoiding public speaking, over time it weakens the link so that you're able to public speak without having, when you realize that there were no negative consequences of public speaking. The emotion elicits new action tendencies rather than always escaping. So when you have anxiety about public speaking, instead of just retreating and having that as your only choice, you can actually think back and realize nothing bad happened, I don't have to retreat, I have other options. So all the way opposite action refers to doing more than just the event itself. So for example, when you're public speaking, you don't want the patient to just get up there and speak. You want everything about the presentation to be the opposite of what they may have otherwise felt. So they're going to use facial expressions, they're going to use different body language, they're going to slow down their speaking and their breathing, use opposite thoughts, motion. So everything about the patient itself, you're going to focus on the opposite of what they may have otherwise wanted to do. And this broadens the cognitive responses to emotional experiences. So dialectics, again, balances the acceptance-based and the change-based interventions. You can change the speed and intensity of the therapy. You can use movement to keep the patient awake, attentive, and slightly off balance. And when you talk about off balance, you're referring to the patient never quite knowing what the therapist is going to ask next or do next. And it just keeps them more attentive and focused on learning because it's not just something where they know exactly what's coming. You can provide in vivo learning experiences to practice new behaviors. You can play devil's advocate. For example, you could actually argue with the patient why they shouldn't commit to some change that you've been talking about, hoping that the patient then comes back and tells you why they are going to commit to the change and all the benefits that they would have if they changed. So essentially they're reinforcing their motivation to change. The therapist can model skillful movement between polar opposites, helping the patient become less rigid. So the patient can see that it's okay to be happy and sad, and you don't have to be so rigid in one way. It helps decrease polarization between the therapist and the patient. So it's okay for the therapist to validate the patient saying, I see why you say that, but at the same time, this is why I'm saying what I'm saying. So it's not kind of giving up your point of view. It's not saying, you're right, let's go with exactly what you're saying. It's acknowledging that there can be absolute truth, but there can also be many truths. It's not one way or the other. The third part of DBT is the telephone consultation. So this helps integrate learned behaviors into the patient's natural environment. So the therapist may be the stimulus for practice. So when you talk to the patient on the phone, it may remind them to be working on these skills. It can serve as cues to retrieve memories that you've talked about during therapy sessions. It gives the patient a way to reduce crises before they act on their dysfunctional behaviors. It's a chance to repair therapeutic relationships. So if you've done something during the session, you don't have to wait until the following week to try to repair it. In the meantime, having the patient sit at home wondering what went wrong and resulting in some dysfunctional behavior. And it increases the patient's problem solving and helps them to learn to ask for help. This isn't to say that you give the patient your phone number and say, call any time of the day, whatever you need, call me 50 times. You can set limits on how they use the telephone consultation. And that doesn't have to be something you do at the very start. You can see how they use telephone consultation. So if they're calling, once in a while when they're actually in a crisis, that's reasonable. If they're calling 50 times a day at all hours of the day, then you may have to set some limits. And another example of a limit that was suggested was if a patient self-harms and then calls you, you may actually have a restriction that they're not allowed to call you again for 24 hours in order to not reinforce that self-harming behavior. Whereas if they had called you before they self-harmed, it would have been different. That would have been them asking for help. The therapist consultation team is a way to provide support and training for the therapist. So it focuses more on the therapist's behavior rather than the patient's behavior. So is the therapist showing up late, showing up unprepared? When they're talking about a patient, are they using derogatory remarks? Are they acting defensive? And it's a way for other therapists, other group leaders to point these things out to the therapist. It helps maintain the therapist's motivation and effectiveness, so they have someone to bounce ideas off of. They have someone to kind of keep them in check and say, you think you're doing this, but this is what we see. And it helps the therapist continue to progress forward with the treatment rather than maintaining in the same spot just because that's easier. So one study looked at the cortisol level in therapists and found that initially when therapists are starting DBT, cortisol levels, so the stress is higher than with other traditional therapies. However, over time, after about 6 or 7 months, the level of cortisol is significantly lower than with other therapy styles. So it's thought that the initial high cortisol level is because you're learning something brand new that most people aren't experienced with, rather than something you've been exposed to more like CBT. However, it was interesting because part of why you have this therapist consultation team was to prevent therapist burnout, because these are difficult patients. But the study with the cortisol actually saw that when you're using DBT versus any other sort of therapist, the burnout level is essentially the same. And surprisingly, they were both very low. So we're going to look at just a few randomized controlled trials and component analysis. So there have been at least 7 randomized controlled trials with 4 different teams. So this isn't all just one group looking at all the studies and coming up with what they want to see. It's 4 different teams. One such study was done from 2004 until 2010, and they looked at patients in treatment for 1 year as well as the 1 year in follow-up. There were 99 women in this treatment. The mean age was 30.3. They had exclusion criteria including seizure disorders, having an IQ below 70, current psychotic or bipolar disorder, or requiring treatment for some other life-threatening behavior such as anorexia. The inclusion criteria included having borderline personality disorder with at least 2 suicide attempts or non-suicidal self-injuries within the last 5 years, having a suicide attempt or self-injury within the 8 weeks prior to screening, and having at least 1 suicide attempt within the last year. This study was conducted at a university as well as community settings with therapists and case managers. There were quarterly evaluations of the patients by blinded assessors, and then they compared. There were 3 different groups in this study. There was the group receiving standard DBT with all 4 components of the individual therapy, the group skills, the phone consultation, and the therapist consultation. There was a team that received the skills training plus case management, but no individual training. And the reason behind the case management being added to the skills training group was just so if there was a crisis, there was someone who could help out there. And then there was a 3rd group who received DBT individual therapy plus activities group, but no actual skills training. So they weren't allowed to teach DBT skills, but they still had activities like going out to a movie or playing a game with other people. So they still had some interaction with others, but no actual skills training groups. And then they used a variety of self-questionnaires and rating scales to determine how the patients were doing. So this is just a breakdown of how they obtained the patients, and in the end there were 33 people in each of the three groups: the traditional or the standard DBT group, the skills training without individual therapy group, and the individual therapy without skills training group. And this, you all have a copy of this, but this is just a breakdown of how the different groups varied. And this is the Reasons for Living scale, which is one of the scales that was used during the study to monitor how the patient's doing. And I had not seen it before, so I just thought I would include it. But it's a series of statements, and the patient rates how important it was for them, and it's a way to assess their reasons for not wanting to die. So the study's results showed that between the three groups, there were no differences in the number of psychotropic medications used. All groups had a similar improvement in the frequency and severity of suicide attempts, suicidal ideation, and the use of crisis services due to suicidality, as well as similar scores on the Reasons for Living scale. Compared with individual therapy groups that received skills training, so the skills training group and the standard DBT group, had a greater reduction in the frequency of non-suicidal self-injury acts and depression during the treatment year, but not necessarily during the follow-up year. Compared to the skills training group, the standard DBT group had 2 to 2.4 times lower rate of suicide attempts, ED visits, hospitalizations in the follow-up year. There was significantly improved anxiety during the treatment year for standard DBT group and the skills training group, but not in the individual therapy group. However, in the follow-up year, anxiety and depression improvement for the individual therapy group caught up to those that received the skills training. So there was equal improvement in all the groups, but it was a slower improvement when they didn't receive any of the skills training. And this is a table comparing the standard DBT with the individual therapy. So you can see that the dropout rate was lower, the ED visits and follow-up was lower, and the psychiatric hospitalizations and follow-up was all lower for the standard DBT group compared to the individual therapy group. However, there was no difference in the visits or hospitalizations for suicidality during treatment or follow-up. So some general outcomes of DBT studies that have been looked at. With DBT, patients are less likely to be parasuicidal. And parasuicidal refers to suicide attempts, threats, making plans, high risk, like self-harm behaviors. They have less medically severe parasuicides, so when they do something, it's less severe. There are fewer treatment dropouts, fewer inpatient hospitalization stays, and fewer days used during those hospitalization stays. They improved more on scores of global and social adjustment. There was significantly more reduced anger and hostility, and this was in borderline personality disorder patients as well as a host of other diagnosed patients. There was greater reductions in depression scores. There was significant improvement on suicidal ideation, hopelessness, dissociation, greater reduction in illicit substance use, and decrease in bulimic behaviors. One study did reveal little difference between DBT and CBT after 1 year. However, a Cochrane review concluded that DBT is still the only treatment with sufficient replication to be considered evidence-based for the treatment of borderline personality disorder. I'll come back to this, but I included the Linehan Suicide Risk Assessment and Management Protocol just because I had not seen it before, and it was pretty detailed and included a lot of information that we think about every time we see a patient, but it may not necessarily be true. And so it's worth taking a look at. It goes through a host of imminent suicide risk factors that you can evaluate with patients, as well as suicide protective factors, and there are many more on each of these sheets. I just didn't have room to include them. So you look at the imminent suicide risk factors as well as the protective factors, and then it goes through the actions that you took in order to minimize the risk of the patient harming themselves. So did you focus on validating the patient? Did you formulate a plan? Did you talk about safety planning? Did you refer the patient somewhere? Did you hospitalize them or not? And if you didn't, what was your justification? So it's all stuff that you tend to do when you write notes, but maybe just not in this much detail. So if you're really worried about a patient, it would be worthwhile to take a look at this and do something similar so you cover all your bases. And then your final disposition is, like I said, what did you do with the patient and how you got to that decision. And then, let me see here. So this is Martha Linehan, just a short minute talking about DBT. No, possibly. I don't know how to get the sound on. Yeah. It's on mute. Well, it's not crucial. Basically, it's just her saying that the goal of DBT is to bring patients out of this hell that they feel like they're living in and to keep them out of this hell. It doesn't have to be all at once. It can be over time, but that's the goal, is to help someone live a happy, normal life. These are my references. And then when I thank the fellow residents, especially the PGY4s, my co-chiefs, Kari and Zach, Dr. Caudell and Dr. Fitzgerald, Dr. Tasman and Dr. Casey, Christy, who does all kinds of stuff for us, my supervisors, Dr. Roberts, Dr. Casey, Dr. Vincent, Dr. Feldman, Dr. O'Connor, who helped give me some resources for the presentation, as well as family and friends, especially my parents, grandparents, siblings, husband, and my dog, just because. And that's it. I'm calling it. I'm done.
I just have a question about how frequently you sense that the standard DBT is implemented in clinical practice.
Yeah, not
I know a lot
frequently.
of people talk about DBT and using it as an element of practice, but here's the full package. What's the best?
Right.
It's pretty tough to pull off. You have to have all those resources.
Right. So in addition to having the resources for the patient, you also have to develop a whole team to help the therapist. So it's a lot to try to pack into 1 week for all of these patients, the individual therapy, the group therapy, in addition to, does their insurance pay for it? So it would be very difficult to have the full standard DBT, but you can at least take components of it, different techniques from it, and even if you only have individual therapy, you can maybe try to add in some of those skills components to the individual therapy. But it's not, the full standard DBT is not used often. There just aren't the resources for it.
Are there any self-help guides or manuals that are useful for DBT that therapists could use in their practice to try to help patients gain DBT skills?
I'm sure there are. I do not know what they are, but one paper I was reading talked about how, similar to with CBT, how they're developed. Now there are computer modules that patients can do. They're at least starting to work on those for DBT. So even if the patient can't get there for the full skills training groups, they can work on these modules on their own time. And I don't know that those have actually been released yet. But.
Another question is what the group, maybe you or the group, thinks about giving the patient your cell phone number and being available to them, particularly if they have something like borderline personality disorder.
I personally wouldn't do it. That was another thing that came up in some of the papers is, in the past this was the norm. You gave all of your patients your phone number, but that's not necessarily the case now. So if you do choose, it's a personal decision. You have to know the patient. You have to decide what's right for you. But if you choose to give the patient your phone number, you have to be willing to also step back and put limits on the use of that if they do start abusing the privilege of having that number. So like I had talked about before, whether that's, you called me after the fact of hurting yourself, that doesn't do us any good. That defeats the purpose of having my number. Therefore, you don't get to use my number for the next 24 hours or whatever it is. But there is a risk involved with giving patients your number, definitely.
I imagine there are differences among the clinicians in the group. I do this with many patients that I have a concern about suicide risk as part of the suicide safety plan. But I guess that I probably would have certain patients that I'd be real hesitant about.
Right.
Fortunately, I don't have, I shouldn't say fortunately, prejudicial if it's poorly. I really don't have any in my practice that have, a full-fledged poorly.
Right.
And that people are skilled in that and have affinity for that are better than people.
Mm-hmm. Yeah. Another risk you encounter when you do give patients your phone number is you're telling them, call me anytime you need me. So you have to be available anytime they need you. And now with cell phones having, messages, they can leave you a message and you may not see it for 6 hours. Well, they've left you a message saying they're going to kill themselves, and now what? So there are definitely risks involved that you have to think about and weigh carefully before giving out your number. Right, I agree. Another option that we have now is because we do have answering services, you could set up so that normal calls go to the answering service, but if a patient is suicidal, then they would forward the call on to you. So you're not getting every little call, they got their feelings hurt today, but you are the one to manage the major calls, the suicidal patients. Dr. O'Connor. Right. Mm-hmm. Right. Well, when you think about borderline personality disorder, one of the key things is they feel alone. They don't have interpersonal relationships that are long-standing. So if they're consistently going to see the same group of people every day, that loneliness is less likely to be there. And I mean, we do have people coming into the emergency department every hour of the day just because they don't want to be by themselves, because they want to talk to someone. It's not necessarily that they're going to go kill themselves. They just don't like being alone. And so if you're consistently meeting with a group of people every day, that kind of serves that purpose. You also get to hear other people's stories that relate your experience to what other people are going through. So yes, you're feeling bad, but you may not be feeling as bad as that person next to you. Dr. Lippman. And Dr. O'Connor made a good point that was brought up in the papers, that we should probably reinforce, that these aren't telephone calls for therapy, and you do have to remind the patients of that these aren't just therapy, it's to work on the skills. And when you have your patients, do you do the contingency management before you get to those calls? Right. Mm-hmm. Right. Dr. Casey.
Not exactly a question, but just sort of for your comment and the rest of the psychotherapists, psychotherapy teachers in the room probably have grappled with the same notion, and that's the idea of superior psychotherapy. So if you're taught to be a cognitive therapist, and that's the model you're trained with, and then you read a good deal about DBT, a similar but not identical kind of therapy, and you learn the certain elements of that therapy seem to be very helpful to the kind of patients that you see. We haven't been fully trained in this new area. Inevitably, you're likely to press into service some of the things that you've learned or read about in the hopes that it may help these patients.
Right.
And I would say that that's true. It's inevitably true for most practitioners. If you're trained in dynamic therapy and you're proceeding to address patients, you learn that certain elements of cognitive therapy can be very helpful in these patients. You're very likely to incorporate that into your model. And I think that's likely to happen frequently in the real world. So I'm often left thinking, is this a good thing or not a good thing? Is adherence to a particular model, as some people believe, so important that we shouldn't borrow from other models? If we do borrow from other models, whatever primary models we were trained to try to practice, does that muddle things? Does it end up being sort of doing a half-good job and being wholly eclectic? I don't have a very good answer for that, but it is, it made me think about it, the Cochrane review, his comments that DBT is the only
Right.
evidence-based treatment. I'm betting that lots of cognitive therapists out there, in fact, have modified their approach to their borderline patients through trial and error, and also through their discussion with other therapists, or their reading about DBT and other approaches that may be useful. So I'm kind of curious about what people think about it. Is it a good thing or a bad thing that we become more eclectic?
Right. So ideally, you're picking and choosing what works for the patient. The goal is to help the patient improve their functioning in life, and so you pick and choose parts of whatever model are helpful. And like Dr. Wright was saying, it's unlikely that you're going to go somewhere that's practicing the full DBT, the 4 components of DBT, but if you're able to pick out certain skills that you can apply to the patient, that's helpful. What does anyone else think about kind of labeling the different models of therapy? Glenn Gabbert.
There are clearly people like Dr. Gabbard who feel perfectly comfortable with developing an approach for that particular patient. They may borrow from other approaches, or you may have an ad hoc approach for that person. There are lots of other options for people that really believe that it should not be a question. Stick fairly rigidly to the model that you've been trained and as an evidence-based approach to work with. I think that the concern is you're going to so if you lay out a rationale about why you're going to focus on the thought process, and then all of a sudden you shift over to the DBT approach, you figure out that you realize that you can't do it. Now there is not so much to focus on internally what's happening in your head, it's more possible operational behavioral paradigm. So the opposite of emotion is that is cognitive. And so now you're trying to approach maybe a similar problem from a different way, but you're trying to do the same rationale. And so I think it's okay to get help as long as you have a good understanding of the mechanisms that you're trying to focus on and how the nervous responds to it, and that you explain that to the client so they understand all this new change, this skill set. And that's kind of a lockstep that I think everyone runs through it. I have a comment too. I think that we have to think about active practice of therapy for someone like Dr. Gabbard, who's highly skilled and very experienced therapist and knows couple of therapists very well, learning psychotherapy. I get a little worried by eclecticism from the get-go and not having enough time and experience to learn 1 or 2 or 3 therapists pretty well. I think that kind of approach probably puts you in good stead down the way as you might think about customizing therapy. As a raging debate, as Dr. Casey brought up, that certain people who write in this field that think that there really are no differences between therapies, it's all appear to be certain evidence for that. And there are a lot of comparative studies also that found that certain populations one therapy works better than others. That's a tough thing to answer.
Yeah, that is a good point, though, that you have to know the basics of how to do each type of therapy before you can start combining and picking and choosing.
Yeah, but let's take an example. There are illnesses too. Say you have bulimia.
Right.
Are there certain treatments that we know have pretty good evidence they work, and there are other treatments that really haven't been shown to work very well. I think that clinicians should know those data. Example for OCD. What treatments work for OCD? Do you use psychoanalytically oriented therapy for OCD or not? So I think there's a lot to be learned.
Absolutely.
One more comment. I really want to thank you for and you're right. We don't do a lot of looking at our practice also, I have had 2 patients with borderline personality who actually sought out and found me in the community. People on the other side of being a therapist, realizing we need to train therapists that do know dialogue
And if you go to the Behavioral Institute website, there's a link on there that has resources where you can purchase all kinds of stuff to help patients.
The only comment on it is I know people that advertise themselves as providing a certain kind of healthcare at CBT or DBT. In talking to people that see those therapists, I'm pretty dubious that they actually have the skills that they claim on their website or on the business.
Thank you.